And welcome to the Dr. Bob Show. Your foot is your best friend and very slow to heal. We're going to be talking on this show on common foot problems, what we can do to prevent them, and what we can do to treat them. My guest is Dr. Kendale Ritchey. Dr. Ritchey is a board-certified podiatrist. He deals with foot problems every single day, and he's got a wealth of information for you and me. I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. I'm hoping by the end we'll know how to keep our feet healthy so that we won't have common foot problems. You'll want to stay tuned. We're talking with Dr. Kendale Ritchey, board-certified podiatrist, foot specialist, and we're going to be talking about common foot problems. I'm going to start off with plantar fasciitis. Kendale, welcome to the Dr. Bob Show.
Thank you, Dr. Bob. It's always a pleasure.
Well, what is plantar fasciitis? Everybody's heard about it, and a lot of people have had it.
Well, so essentially, the plantar fascia is a ligament on the bottom of the foot. It's a very strong, dense band of tissue, and it attaches to the heel bone, runs clear underneath your arch to the area underneath your toes. And so this ligament has two main functions. The one function is to protect the intrinsic structures of the arch. So it provides a very nice barrier for any type of a penetrating injury.
So if I hit it or if I tried to put a nail into the foot, it would give some resistance and maybe some true protection.
It would. The intrinsic structure of the foot, there's 4 layers of muscle, and in between each layer runs the nerves, the arteries, the veins, and the main tendons. And so you want to protect that area.
Big time, big time.
Now secondly, it acts as a tether, and it binds the heel and the toes together. And so you can picture the arch sort of like the bow of a bow and arrow.
Yeah.
Correct. And so the plantar fascia would be the string going from the heel out to the toes. And so it prevents your arch from collapsing too far down when you stand up, and of course gravity is going to push down on the arch.
It's an arch protector. It's a protector of blood vessels and veins and nerves, everything that's under the foot. So it's terribly important. Where does it attach on the heel? Where does it attach? Just the round part of the heel?
Yeah, right. Well, I can show you on this. Yeah. So basically, if you take this skeleton of the foot, we can turn it over and we can look. This bottom bone right here is called the calcaneus, and it attaches right to the bottom of the calcaneus. So it's sitting like this.
Yeah, and this would be your plantar fascia right there.
Exactly.
And it ends up over here somewhere on the toes.
It actually, this is a little bit shorter than it is in real life. It actually comes all the way underneath the ball of the foot here. So when you stand, obviously gravity is going to push down this direction, and it's going to resist collapse of the arch.
Yeah. It's neat the way the foot is made.
Oh, it's amazing. Yeah.
Lots of bones in the foot?
Yeah, there are 28 bones.
28 bones.
If
You've got to know every one of them. I remember in medical school we had to figure out some way to remember all of the bones that way.
If you add the bones together in both feet, it makes up a quarter of all the bones on the whole body. So there's a lot going on down there.
Yeah, and there's a lot of things that can go wrong. So what goes wrong with the plantar fascia?
Well, so essentially what happens is plantar fasciitis, or inflammation of the plantar fascia, is an overuse injury. And the weakest link in the whole chain is where that fascia attaches right to the heel bone, and it will start to become inflamed.
And when it's inflamed, if it attaches to the heel bone, you have pain in the whole foot or on the heel? Where's the pain?
Well, I would say the majority of time it's directly right on the heel. When you go to stand, you'll feel like you have a stone bruise underneath the heel. Now it doesn't always happen at the heel. It can happen in the middle of the arch or even a little farther out towards your toes, but 90% of the time it's going to be back into the heel. Yeah.
And when somebody comes in limping and they say, my heel hurts, I've got a stone bruise, you're thinking right away it's probably plantar fasciitis. What other symptoms do you ask them about?
Okay, so the second thing I'm always going to ask them is I'm going to say, when does it bother you the most? And the majority of the time, they're going to say, when I first get up in the morning, I can barely walk on it. Or if I get in the car and I go for a nice drive, when I get out of the car, I can barely walk on it. So we call that post-static dyskinesia, or pain with movement after rest. And so that's sort of a pathognomonic finding of plantar fasciitis.
So when somebody gets out of bed, oh, it really hurts. Can they massage their foot? Can they do something to the bottom of the foot?
So I recommend that before you even get out of bed, you lay there and you pull those toes back and you stretch that plantar fascia as much as you can. And rub it real good from the arch all the way back to the ball of the heel there.
So you sort of massage it with your thumb, and you dorsiflex the foot. It's my big word of the night.
That is a big word, yes. Dorsiflex meaning pull those toes back towards your face.
Are there certain type of braces that you wear at nighttime to keep that foot in the right position?
So when we talk about treating plantar fasciitis, there's really two main parts of the treatment we want to talk about. The first thing is we need to get rid of that inflammation. The second thing is we need to alter the reason you're having it in the first place. And so that's where the orthotics come into. What we're trying to do is we're trying to support the arch so that when you stand and walk, it can't come down as far. And so that plantar fascia essentially doesn't have to work as hard. So when it doesn't work as hard, there's not as much tension on the plantar fascia, especially where it's attaching to the heel. So getting rid of the inflammation and altering that with an insert into the shoe is very beneficial.
Are there certain types of orthotics that are more dome shaped, that are more bouncier, that are better, or not necessarily?
Well, I like to sort of bridge the gap. You want a good amount of cushion on your orthotic. So I'm not a big fan of a very rigid orthotic. Some of these are made out of these real high, almost like glass type of orthotics. But in the same line, just a simple flimsy cushion, that's not enough support either.
So we get orthotics, and that helps support. How do we get rid of the inflammation? What do we do for that?
So the inflammation is addressed several ways. In the office, a lot of times I will use a cortisone injection if it's been really persistent. We'll use oral anti-inflammatories, and that could be oral cortisone, or that could be a non-steroidal anti-inflammatory.
Like an ibuprofen type medicine?
Ibuprofen would be a good non-steroidal to start with.
And you have to know the side effects of all those, because they can, if you take them too long, they can bother the kidneys, but at a short period of time can bother the tummy.
That's correct.
And cortisone by mouth can cause problems too. So you have to.
They all have. That's why we have so many different options, because we have to adjust with each patient.
And when we say there's no free lunch, so you really, if you take any medicine, you got to know there's some side effects.
That's right.
So discuss those.
And also interactions with other medications are an issue as well.
So are the anti-inflammatory medicines, do they work good? And does the orthotics work well? And does the massaging, does that work?
It works very well. In fact, you have to be persistent. It's not a one and done thing. So when someone comes in with plantar fasciitis, they say they've had it for 3 or 4 months. I tell them, guess what? It's going to be 3 or 4 months until you get rid of it.
They said, no, I thought you were going to give me well today.
Sometimes that does happen, but it's a persistent thing.
Now, what is happening in the plantar fascia? Why is it becoming abnormal? What does it do? I mean, what's happening?
Well, chronic inflammation, when it surrounds soft tissue for a long period of time, it can start to weaken it. And as it gets weaker, you will start to get some degeneration, I guess you would say, of the tissue, and you can also start to get some microscopic tears. Of course, the more that happens, the more the inflammation gets greater, and so you get into this cycle where you're getting inflammation, tears, and you can actually have an actual separation of the plantar fascia long term.
I was amazed. I was in your office. I've got some foot problems, and you were saying taking care of a plantar fascia that's completely torn right in the middle versus little mini tears. Which is probably the best or easiest or worst?
Well, neither of them is good. But I would say a total rupture of the plantar fascia is easier to deal with than the small tears.
That's what it just didn't make me. It said, wow, why is that?
One of the things that we do, if you have plantar fascia that is completely recalcitrant, in other words, it won't get better with all the conservative measures, one of the things we can do is we can surgically lengthen that plantar fascia. And we do that with an endoscopic plantar fasciotomy. So basically, you do a knee scope with a camera. We do this down on the heel. And we literally cut the fascia so that it separates and lengthens. So if you accidentally rupture it, you've done that on your own. So you have basically done your own surgery. If you don't and you just have partial tears, then you got a problem.
You got a problem. Yeah. And it's going to be long term, but the results are?
Oh, the results are good. Sometimes it takes a while to get the right combination of treatments. For some odd reason, plantar fascia does not always act the same way on different people, and so one thing might work for one person and one thing might work for another. I kind of use the shotgun effect. I throw the kitchen sink at you, you know. So, but yeah, so that's just kind of how it works.
So when I had plantar fascia, I was just typical of everything that you said. It hurt, the heel hurt. It worked good if I massaged the foot the first thing in the morning. And as the day went on, you went good unless you stopped and then got back on it.
Right.
Long-term, good results. You can take care of plantar fascia. It has to be it should be looked at by a podiatrist, somebody that's their ball game.
That's their ball game.
So, all right. Yeah. So what about other forms of foot problems? And I'm going to go right into diabetes. Does diabetes cause foot problems?
Oh, yes.
And that's what we're going to be talking about when we come back. Oh, yes. And does it ever? And there's a lot that we can do to help and a lot that you need to know to prevent that happening to you. Stay tuned. We're talking with Dr. Kendale Ritchey, board-certified podiatrist, foot specialist. We've been talking about the underside of the foot where the plantar fascia is there to protect the arch of the foot, to protect blood vessels that are behind it, and it's so important. If you have problems, the pain usually starts in the heel, but it can do anything that it wants. Classic, it's worse in the morning, and it takes proper treatment of inflammation and also stretching the foot. Is that pretty good summary?
That sounds great. Yeah, you're hired.
That's right. So I want to talk now about diabetic neuropathy. Yes. That's a big, long word, but it's a huge problem with people's feet. What's diabetic neuropathy?
Okay. Well, Dr. Bob, neuropathy is basically a wastebasket term. It means disease or damage of nerves. But when we're talking specifically with diabetic neuropathy, I like to tell people to picture their nerves like an electric cord. And so you have the wire with a protective coating on the outside. Okay? If I were to take a pocket knife and whittle away that plastic coating, you're going to expose the wire and it's going to short out. Well, when you have diabetic neuropathy, what happens is elevated blood sugar over an extended period of time is going to start to damage the coating on the nerves. It sets off an enzymatic system that starts to degrade, and that's called the myelin sheath. And so when that happens, your nerve misfires. It usually starts at the tips of your toes, and it sends a signal to your brain that something is going wrong. Usually your brain interprets that as tingling, burning, stinging, pins and needles, etc. And so it starts at the tip of the toes, and it gradually starts working its way up the foot like you're rolling on a pair of socks.
So when that happens, what do you see when somebody comes in with diabetic neuropathy, and how do you tell people to treat that? You want to find it early, of course.
Yeah.
How do you treat that patient?
Well, unfortunately, neuropathy is not something you can see. It takes special testing to actually get a quantification about how bad it is. But it goes along with vascular disease as well. And so what
vascular would be blood vessels.
Yeah, blood vessels, the circulation getting down to your toes. And so when someone comes in and they don't have any pulses and their toes are white or blue and they don't have any feeling and don't realize it's going on, what we usually see are things like corns or calluses that will turn into ulcers. That's a sore, an actual opening in the foot where you can see the live tissue underneath. They'll have ingrown toenails that can turn into infections, and they don't realize it because they don't feel it. When you don't have the circulation, it doesn't heal, and then comes infection.
Oh, wow. So it's an ongoing process, and all because the blood sugar's high, the blood vessels get damaged, and they damage the nerve endings. You don't feel the feet, and so you don't recognize when something bad goes on there.
Yeah.
Can people, do they feel the end of their toes, or they feel numb or sort of funny?
It has a whole spectrum, but usually starts with a feeling of tingling or buzzing. But as it progresses, it can get to complete just no feeling at all.
Okay. When somebody comes to you with a bad foot and it's diabetic neuropathy, and you say, oh, we got some problems here, how do you take care of that foot?
Well, once you have neuropathies, there's really no cure. However, there are some things that can really help. For instance, there is a vitamin supplement, they call it a medical grade food, and it can supply all of the nutrients that the nerve endings, the micro nerve endings need to help reestablish themselves.
You got the name of one of those vitamins?
Metnex is one of them. It's a prescription, it's not over the counter.
Pronounce that again.
Metnex.
Metnex.
Yeah, it's a weird name. It's a weird spelling too.
Yeah. So what it does is supplies some nourishment.
Yes.
But your purpose would be to keep that foot from getting actively infected before it gets infected. What do you do?
Yeah. Well, you have to do good foot care.
What is good foot care?
Good hygiene. So first of all, your feet need to be examined at least once a day. I recommend twice a day. Many people can't see the bottom of their foot.
Yeah.
So what I ask them to do is put a mirror on the floor. And just kind of hold your foot over the mirror so you can see the bottom. You're looking for red spots or sores, or maybe you've stepped on something and didn't realize it was there.
You see a little blood on your socks or something like that.
Absolutely. I see that more times than not. People will come in, I didn't know that until I saw that blood on my sock.
And then when you see that blood on your sock, you say, uh-oh, we got to heal this quick.
That is a hot spot.
So how do you protect that foot from getting worse and worse and worse and creeping up the leg?
Well, if there's any active infection, of course, you want to treat that with antibiotics. We also do wound care for wounds that are open. There are different various creams. There are collagen powders, all kinds of very advanced wound cares, which is, that's a whole lecture in itself on that.
So if you've got a big open wound, sort of a gross wound, people kind they don't want, and you can see way down in the bottom of the tissues because it's so bad, you keep that clean.
Yes.
What's a wound vac?
So a wound vac is basically, you can think of it like a sponge that they're going to put into the wound, and they're going to cover it with a barrier that creates a suction. They'll hook a vacuum to it. It's a small little box off to the side, and it sucks tissue and it sucks infection, and it brings everything to the surface and try to stimulate that wound.
Do a good job.
It's a great device. You can't walk on it though. That's the mistake a lot of people make, is they'll walk on those.
So I've had some people tell me when they had a wound vac, you could almost see the wound just healing day by day. It was like it was amazing fix.
It is
there.
amazing.
But you've got to see the doctor. It's not a crime to have a wound and a problem. It's a crime not to see the doctor for it.
Yeah, people will ignore it.
So there's things we can do if it gets real bad. There's some things that we can do to prevent those. How about cutting the toenails? How about ingrown toenails? What do you do for those?
Yeah. Well, there's a proper way to cut it, but a lot of times people will have nails that become thickened.
Yeah.
With poor circulation comes thickened and brittle nails. Then they can get infected with a fungal debris, and then so it's very difficult to trim. In that instance, I always recommend it needs to be professionally done.
So how often should a person with a bad foot from diabetes, and they've got neuropathy, how often should they visit the doctor, or everybody's an individual? Right.
Well, if you're actively treating a wound, we probably see these patients at least once a week, sometimes even twice. If they're a diabetic who doesn't have any wounds, or had a wound in the past but it's healed now, a lot of times we'll say about every 3 months they need to be examined. And so a lot of times we'll do just general foot care while they're in there being examined. We'll trim their nails or trim corns and calluses, just make sure that those areas aren't going to turn into something that they shouldn't.
When you catch a diabetic neuropathy foot early, can you frequently keep that foot
Yes.
in good shape?
That's a great question. I get asked that a lot, and the simple answer is yes. We have found out by good foot care, proper shoes, and then getting into a really good program for monitoring their blood sugar and keeping that under control. Of all the things we do, I'm going to say the most important thing isn't even in my field, and that is get the blood sugar under control. Because if your blood sugar is under control, you're not going to develop the arterial disease, the circulation, you're not going to develop the neuropathy, and your immune system is going to be stronger. And those three things right there are just, you can't put a price on that benefit.
When you've got type 2 diabetes, adult onset diabetes, the kind that everybody's got sort of thing, can that cause just as bad problems?
Absolutely.
Absolutely.
Sometimes worse.
Yeah, sometimes worse
Yeah.
because we don't pay as much attention to it.
They don't, that's right.
Now, are there other problems of the foot that you see all the time? Bunions, blisters, other things like that?
Hammer toes, they all fit into that category.
And that's what we're going to be talking about when we come back. Wow, I never knew there were so many problems that could go wrong with my feet. You'll want to stay tuned. Your foot is your best friend, slow to heal. We've been talking about plantar fasciitis. We've been talking about diabetic neuropathy. Those are very important things that you keep in touch with your podiatrist to get well. Now we're going to be talking about something, let's see, what part of this foot? Right here. Have you ever had somebody had a knot in their foot right there? What's a bunion?
Well, Dr. Bob, a bunion is basically the common name for what we call hallux valgus. That's the medical term.
Hallux valgus.
Hallux valgus, that's
So
right.
hallux is the big toe and valgus is going one way.
Going one way, that's right. Most people perceive a bunion as a simple bump of bone on the side of the foot.
That's what I thought it was.
Yeah, it's a lot more complex than that. So basically a bunion is a hereditary trait. I would say 80% of all bunions are heredity.
Wow.
And maybe 20% of it would be externally influenced by the shoes that you wear, the surface you stand on, activities, sports, etc. like that.
So what happens to the foot with a bunion?
Well, basically what happens to the foot, I'm going to demonstrate on this. The inside, the first metatarsal bone will start to veer away from the second metatarsal bone, so it will slide this direction. And as it slides that direction, the great toe will go the opposite. So as you can see, it's more complex than just a bump of bone.
So when it bends like that, it puts a pressure point on that bone right there.
Right on the first metatarsal bone, which
So
is where it's
somebody gets
sticking
a
out.
swollen, painful bone, right?
They do. They do.
The symptoms?
Yes. The symptoms are a large red knot at the base of the big toe. It rubs in the shoe. It can form blisters. It can form arthritis down inside the joint as well.
Wow, so it's a huge problem.
It's a huge problem.
How do you fix it?
Well, there is no conservative fix for it. There is conservative management. Conservative management would be wearing shoes with a wider toe box. They make bunion shields, which are silicone sleeves that slide over to protect it. There are splints that will straighten the toe out, but that's not a permanent fix. Those only work while you have them on.
So what is it? How do you fix it surgically?
Surgically, what you have to do is remove the bump, but you also have to restore that alignment between the first and second metatarsals, which means breaking this bone, straightening it out, and then fix it in place. There's various ways to do that.
And when you fix it, is it really a pretty good fix?
The techniques have become so much more reproducible now that it is a good fix. There were years past it didn't always last, but if it's done correctly nowadays, it should stay forever.
So let's then go to two more things, a callus and a blister.
Okay.
If somebody's got a blister, do they pop it? How do you treat it? Do you not want to pop it? What do you do with that?
Well, it kind of depends how large they are and how they feel. Some people will develop blisters and they won't be painful at all. And I tell them just to protect it, cushion it with nice socks and good shoes, and leave it alone and let it do its thing. If it's painful, however, I do like to actually perforate it and push the fluid out, and that relieves the pressure.
Yeah, and it feels so much better.
It does.
And then, how do you tell them to take care of the foot?
Well, then they have
fluid will come back.
It will. They have to protect it. They have to make sure that the underlying reason they were getting the blister is taken care of. So if they're wearing a shoe that's too tight, if they're doing an activity that was too much, causing too much friction, they need to lay off that until it heals.
Corns and calluses?
Corns and calluses, basically they're the same thing, just located differently. Calluses are mostly on the foot, corns are mostly on the toes. It is a thickening of the dead layer of skin. You know, there's two layers of skin, the dermis and the epidermis. The dead layer will get thick because of chronic friction or pressure on it.
Can you shave that off?
Yeah.
Is that
That's commonly
that's
what we'll do
treatment?
in the office. We'll shave that callus off, and we try to counsel people on finding ways to get the pressure off that area.
The foot is an amazing part of the body. We step on it every day. So I can see where all the problems, and your knowledge is amazing, but that's all the time we've got. We're going to have to be talking about exercise, how important that is for your life. Be sure that you're getting 7.5 hours sleep. If you get to sleep, you'll be able to function better and you'll be bright-eyed and ready to go. Eat properly. Eat fruits and fibers. Google Mediterranean diet. And most of all, what is it we like? You know, it's that laughter in your life. It's fun to talk with Dr. Kendale Ritchey because we smile and we laugh and we enjoy what we're doing. So be sure, you know, that you are getting adequate time to laugh. Find that loved one, tell funny stories, giggle, have a great time. And the more you laugh, the healthier you'll be the rest of your life.